1981 is when the huge headline in the New York Times that in New York here and in California and San Francisco, they had diagnosed 41 cases among homosexual men, as they were being referred to then, this rare and fatal form of cancer. That's how it was described. And that there was this rapid mortality, right? So this was sort of the beginning. Now, interestingly, what immediately happened was that, first of all, nobody was talking about it in terms of government. Ronald Reagan did not mention it for years. And there was this assumption of who is actually getting HIV. So we started with actually accusing Haitians of being the first cases. So if you were Haitian, suddenly there was all the stigma around this because perhaps Haitians were bringing it into the country. Then, of course, we went to commercial sex workers, injection drug users, gay men. And so these were all populations that in some rhetoric that was out there was like, well, they deserve it. This is God's punishment. During this early time when that was being stated, I had put out and sitting in some of these policy groups that if that's the argument, then lesbians must be God's chosen. So, anyway, so we immediately started this, these are the bad people, right? We started the stigma sort of in this way. This is before we knew the source of AIDS. So this is still a year ahead of that, and just wanted to share, and we've been talking about messaging. So the messages at the time from the U.S. Public Health Service was to avoid sexual contact with persons known or suspected to have AIDS. JAMA, unfortunately, had a piece about evidence suggesting household contact may transmit AIDS. Again, this is maybe sounding familiar in terms of COVID about all the things, bleach your vegetables, whatever. And then, of course, I love this being San Francisco, because it was San Francisco, the messages there were use a condom, avoid exchange of bodily fluids, limit your use of recreational drugs, and enjoy more time with fewer predators. Just a little reflection of the area at the time. But we were giving mixed messages. And so I always love this cartoon that Agnes's AIDS business makes me think we should stop sharing needles. So, again, we're just putting messages out and we think people understand it, right? Don't share needles. Who is that message for? What are we talking about? Why? So this was all sort of going on. I don't appreciate that COVID came about, but I do feel like it helps folks who weren't at the beginning of the HIV epidemic to have a sense of what it felt like, that panic, although it wasn't as large as COVID because it was restricted within communities that were being identified as being at high risk. But that fear, like, oh, my gay friends, we were all talking about it in Boston at the time, like, oh my God, what are these things? What are these sores? What does it mean? Who's going to get it? So there was a lot of fear out there. Finally, in '84, we discovered the virus, we discovered the sources, essentially, of transmission, and that sort of changed the dialogue, right, about who then was going to be susceptible to becoming infected. And it kind of, had to hit some people in the head, like, you can't just say it's these three groups of people because of what they do. It has totally to do with your behavior, and that'll go across all populations. So it started to shift a little bit of that, but the stigma, of course, has been retained. I think really important to understand during this first decade is that it was the community that was organizing and doing stuff because the government wasn't involved, and because of all of the stigma. And so, it was originally called the gay-related infectious disease, GRID, is what it was called before we called it HIV AIDS first, then HIV separately. So these were sort of the main groups where we were responding. I was directing the Child and Family Mental Health Center at Southern Jamaica Plain Health Center at the time, which is a clinic of Brigham and Harvard Medical School. And so we tried immediately to educate our neighborhood. We were a community health center. We wanted to make sure that the residents of our health center were aware. We brought in the beauticians and barbers in our neighborhood to explain, because we felt, and bartenders, because we felt like they were folks that people would talk about their sex lives or drug using habits. And we wanted to make sure they knew enough what we had learned so far about how it was transmitted, why to use condoms, etc. So this was, again, in that first decade, that's really where the work was happening at the community level. We had these very, dramatic policies that were not well received by all. Closure of bathhouses was a huge thing in many major urban cities, which had been a very important social place for gay men or men who have sex with men more broadly. This blood supply and donation policies, as you know, until very recently, gay men were not allowed to donate blood because of the fear of transmission through that. And then probably for me, what still stands as the most honest and direct report is the General Coops, Surgeon General's report that went to every household in the United States. He had to go through many, many things to release this report. But if you have a chance to look it up and see it, I think you'll be surprised how candid a government document could be. Because it was really, in my view, it was the best in the best sense. The other thing that happened that was very different was the activism related to HIV and research. And, this was really about treatment, right? Our focus was really on helping people who were getting sick. We haven't moved too far into prevention yet. It was really the crisis of people dying so quick. What could we do? And so they're just, I'm sure you've heard the histories, but just a lot of activism around people who were getting infected, wanting trial medications much earlier than FDA would have allowed, and really fighting for that, giving people that choice. They knew they were dying. Why not allow them to take an experimental drug and possibly help others? So it really changed things in that whole pipeline of drugs for a lot of diseases, not just HIV. But it was critical. And also it brought interesting sort of communities together. The lesbian gay community were not a united community prior to HIV. They were pretty separate. And a very different sort of unity occurred there where many lesbians were taking care of gay men who were ill. There was just this collective sense of trying to fight for our lives kind of thing. And so those kinds of things changed. And, it's hard to describe, but, what was happening is you would see people walking on the streets with sores. You knew that meant they had AIDS. You saw people, close friends, 2 months later, they were gone. I mean, they had been healthy. That the speed at which people were dying at the time, at the beginning of the epidemic, was overwhelming. And particular areas, were hit more, particular communities, particular, actors, there was just all these different places in which there was really an overrepresentation of loss. So it was a very, very difficult time. And our colleagues were dying. People who came into the research world to study HIV because of their personal motivation. So that meant many of our colleagues, throughout my time at the center, we lost very important people that we had worked with. So very, very difficult. The general public, again, had been somewhat not informed. And so all of this was going on in these communities. But meanwhile, the public wake-up calls that happened sort of were really specific to people. 1984, it was the teenager Ryan White who got infected through transfusion. And made, huge headlines. And of course, as you know, the Ryan White Act was named after the teenager, which is interesting to me because obviously all these other people had died before, but this is what that Rock Hudson. Oh my gosh, there are so many older women at the time who were devastated at the thought of what that meant. Like, how could Rock Hudson die of AIDS? Right? And then, of course, for the African-American community, who really had been sort of like, oh, that's not us, this is the gay white boys. Magic Johnson announces he has HIV, and it sort of changes that whole dialogue. Sadly, a lot of people think he's been cured. Right, that misconception because of all the resources that he had to intervene early. But these were the only places where it was happening. The other place was MTV with Pedro in the storyline, and he lives and dies on the show. And real, MTV. So that was the other place that people really got to see it for sure. For at the course of it. And then, of course, I just wanted to again say that, science came later. The science that was being focused on at the time, again, was treatment, clinical sciences, not prevention. So the first 5 years, we had to find out what people were doing. It had been the 50s since we had studied sexual behaviors, and a lot had happened in between, including a sexual revolution. So, we had to go in, and this was difficult because there were people that didn't want us to be asking these kinds of questions. But that's what we needed to do for the first 5 years. Then it was 8 years before there was actually an empirically tested intervention. And it was only for gay men. So again, just speaking to the lack of rapid response had, in my view, to do with who was perceived as being this. Because things started to shift once it became a broader epidemic. And this is what was happening that we weren't paying attention to. So this only goes up to 2006. But this crossover, which happened before medication, before the cocktail emerged, there was already this really dramatic shift happening. So, and this is why I talk about this as the natural course of disparities, is essentially we start with what is a white, male, gay disease. At least that's how we are understanding it in the beginning. Obviously, there are other folks represented there, but they were not the main focus at the time. And legitimately, that was the right thing to be looking at, because that's where that's what was happening. That's where the need was. However, what we weren't paying much attention to was what was happening over time. And this is, this is not divided by gender, but for white non-Hispanics, you see this dramatic drop. A lot of knowledge was in the community. Folks knew what they had to do to avoid it. That was not happening in other communities who were either denying that they were susceptible or vulnerable, or they weren't being given any information. And so we see this crossover that really, while we were looking at it, it wasn't creating action, going back to sort of the public health model. And, part of the reason I think initially is because there was this desperation to find a cure. And so we weren't being as nuanced in what we were looking at. And we didn't have the frame of equity or social determinants of health. I mean, we were only looking at individual behaviors and what could we do where.
I think the other thing that's important to point out here, these are orphans of cases, not rates per.
That's right.
So it was always disproportionately impacted.
Always disproportionate. Yes.
60% white is probably lower than the proportion of the country that was white at the time.
That's correct.
So
it was always there. It was always there. And targeted efforts were being made. As you can see here, these are different posters for different communities, but that disparity was always there. We weren't just attending to it. The second decade, we were starting to understand more about HIV prevention. CDC started the HIV prevention planning groups. I was a community co-chair for San Francisco. It was a very sort of interesting process, which meant that we were trying within communities to decide what were the high needs of the community. Right? It really was an effort to localize and in some ways customize how the resources were being given. And then, this urgency was underscored in the public eye, like I said, by these different people. We then, of course, had the major breakthrough in 1997 when we found the cocktails. And you have to understand that before that, a lot of people living with HIV were encouraged to put their credit cards to the top, spend their life insurance, like this is it, right? I mean, we have been watching people dying with no treatment. And we had tried some treatments that were horrible, were not working. And then we had this major breakthrough in '97 of the cocktail. That suddenly all these people that had, maxed out on their credit cards were going to have to pay them. So, it was wonderful excitement around this. And as you can see, the dramatic decrease that occurred, representing that promise. But like you said, it hid the reality that among women and among racial ethnic minorities, it continued to rise. So right, correct. And like I said before, I mean, it was at first, we were not really encouraging people because we didn't have the treatment. This always is interesting to me because I really still don't understand why Newsweek decided to discuss AIDS as if we had cured it. And that this was the picture that they decided to put as the face of AIDS. So a white pregnant woman, and then what they said here, as you can read it, the plague years, right? It's like a history piece, brought out the worst of us, but ultimately brought out the best, transformed the nation. It's like, I don't know what they're talking about. Transform the nation. I mean, the story of disease that left an indelible mark on our history, our culture, and our soul. Right. So for those of us that are in the middle of it, I see this and I go, wow. When in reality, the actual faces of HIV were young gay men, particularly young gay men of color. They were these young gay men who hadn't seen that devastation in the first decade. And so we had this really interesting phase where gay men were refusing anymore to have protected sex. Like, our autonomy should come first. You're trying to squelch our sexuality. I mean, it really, was an interesting and, for me personally, unexpected sort of response of the next generation. And we recognized that this was starting to happen as people you couldn't see it anymore, as people were getting treated. But really this, it just says the generation gap. Why have it's just another STD, now that the men's are there. And again, the actual faces of HIV were really starting to show in African-American women, who are now the predominant among women, just much greater incidence than in other groups. And then, of course, through all of this, stigma got worse and worse and worse for folks. In part, and I think, I'm sure you've all heard this, is that, if you ask a person, or if a person says, do I have cancer, your response is usually, oh, that's terrible. And but for people who said I had HIV, what did you do? How did you get it? Very different response generally for folks. And so that stigma, which we talked about here, continues today, was being nurtured all along through the things. So as John said, these disparities were always there, but rarely highlighted. And, how did they emerge? So if we talk about that sort of natural course of inequities, some of these are individual inequities, some of them are structural inequities. All of this was going on at the time, and really started to create some of these inequities that we then saw in incidents over time. So other communities started to be impacted in a very different way, and for different reasons. So I'm going to sort of then move us to what was it that then shifted in thinking about how these inequities emerge more generally. And this, which is a very old model of the health equity framework that was coming from the regional Bay Area health departments, but other health departments later took on different views of this. We actually started to require public health departments to get certified in knowing some of this stuff. But the traditional model, is really on here on the right, where we always just looked at outcomes starting really with your behavior, your risk behavior. Like, what did you do to have this outcome, right? So it's really just your risk behaviors. We did give some validation to individual health knowledge. That was an important contributor. Healthcare access was an important contributor, but essentially, you know, it was, you did something wrong, you got a disease, you died, right? And we didn't consider individuals in any other context. It was really very much at the individual level. And then the socio-ecological models started to emerge of saying, wait a second, these behaviors might actually be happening because of something upstream. So we can't blame it all. It's a blaming frame, rather than trying to understand a broader impact. So I always think of the right side as your health disparity side and the left side as your health inequities, right? So these were things that really are unjust and should be addressed on the upstream. The disparities are what happens when those are different up here. And again, this is from our Healthy People 2030, just trying to put that same idea of social determinants of health, you know, what they are. Not the perfect image, but, you know, just trying to make it easy for others to understand. And of course, you know, trying to shift us from that equity is not equality. It really does mean a different distribution of resources. It's not just giving everybody the same thing, but giving them what they actually need. And so really trying to make that distinction as well. So we tried to define it. Again, Healthy People 2030, our committee was trying to create the best definition at the time. It has evolved since then. It continues to evolve, which I'm excited to see. But really, equal opportunity for all people to be healthy and to seek the highest level of health and well-being possible. The big change there in that language that you may not see was well-being. That was a new concept in Healthy People, had never been used before. But the committee felt really strongly that it wasn't just about health and the medical model sense, but more broadly, well-being. We did view it as a visionary goal because it requires inequities in health, healthcare, living, working conditions, all the things that influence health. So we see it as a striving goal, and not necessarily one that this is absolute that we'll get to. And we tried to you know, clarify these other related concepts. We had a special issue on Healthy People. This is from the issue that the chapter that I led in that issue. And just, you know, just trying to help people with all these different terminologies. When I started the Health Equity Institute, it was 2005. People were like, oh, you mean disparities, right? You're starting a Disparities Institute. I said, no. That's the problem. We're opening a Health Equity Institute, which is about the solutions. But again, we're still trying to make some differentiations here, and still imperfect, you know, and but again, trying to help people understand this was something that was used for something very different, but I felt really sort of emphasized what these differences are, because we again often think about the individual, but somehow it's about their characteristic. Here, what you're understanding is what access to certain things offer you versus when you don't have it. So on the inner circle is the highly privileged, and you have a people moving. You don't even have to walk if you don't want to. You're going to get around there all on your own because of money, influence, education, all the privileges. But as you move out, you see that more and more challenges are put in front of you the farther away you get from access to those privileges and that resource, until, you know, you're a woman of color and you're having to go over boulders and other things just to take the same path. So it's a little different way of thinking about it. Like, what are we putting in front of people to make it so hard for them to reach their destination? In this case, health. So it's just a different way of visualizing it. I'm going to just share a little bit about a study that I did a very long time ago, but it was the first study that CDC was actually the first funder to take the risk to study prevention with positives. And we were doing this Nancy, Katie, and I had done the first study of sort of discordant couples and addressing some of those issues among heterosexual couples. CDC approached us and said, would you be willing to do some of this with gay men, positive gay men? So we said, sure, but we think it should be a national multi-site study. And so CDC agreed to that. And so we started with this. And so the VOICE study studied HIV positive injection drug users. We did a qualitative study first called Venus. These are our recruitment cards, just to give you an idea of how we did this on the street. It would just say, you know, a person would go up to someone on the street, show them this card, and they had a script that said, and if this doesn't apply to you, please give it to somebody else. So you couldn't tell if that person was accepting it or not accepting it. VOICE became the trial later, but our qualitative work started there. These were my national partners. The ones you don't see on the bottom are me, with Kelly Knight, Carol Dawson-Rose working with me. But these were our other partners. And this was a joint funded by CDC and HRSA, which was also unusual. And so they were quite involved. And so it was a great group. We, you know, had a lot of challenges together around the ethical concerns. I mean, can you imagine? So we're studying HIV positive people and their sort of interaction with negative people, and how are we going to intervene? There was a lot of discussion on the streets about why are positive people being made responsible? Shouldn't the negative person be responsible for their own health, et cetera, et cetera. So all of these issues were happening at the time. Our goal was really to reduce the practices that could transmit HIV, to increase access to use of primary healthcare. We already knew that medication adherence would really decrease their likelihood of infection. This was before we were certain about that, but we were headed in that direction. But at the same time, we knew that, you know, in order for it to really be well received, we needed to understand what our population wanted to do. And this is where I think in the different talks that we've had over the last few days, it just, you know, emphasizes how important it is to hear what the motivation of your potential research subjects are. So when in the qualitative study, we really learned, this is the intervention study, but the qualitative study, we wanted to know what would inject HIV positive injection drugs, what would bring them into a research study, what kind of training would they want to help other users who still weren't infected. So that's how we talked about it with our active users. And for them, it was incredibly altruistic. They wanted to help other users not get infected. And so this, you know, this was sort of our study description. As you can see, each site was getting 300 HIV positive injection drug users. You see all our eligibility. They were coming in, doing a computer assisted survey. We were drawing blood, and they were randomly assigned to an intervention control condition. We followed them at 3 and at 6 months, and then they came back for a 12-month, where they also had the opportunity to do some debriefing, qualitative debriefing. The issues that really came up, and I mentioned this the other day, was the commodification of HIV that was happening at the time. And it was just a sad story of resource. You were better off if you got infected. At least this is how it was being talked about on the streets, because first of all, you know, if you're isolated with lack of resources, they could open things up for you. You would get housing, drug treatment, welfare benefits, and a very relationship value with partners. Which again, we had heard a little bit in our heterosexual study that the negative partner was like, no, I don't care if I get infected, you know, and you know, it brought us closer together. With the injection drug users, it was like, they want to be with me because I'm positive and I can get housing and I get, you know, so there was all of this other stuff going on. There was really, again, difficult to recognize that was some of the motivation. Ultimately, we ended up with this 10 sections, 6 group sessions, 3 individual session, and then what we thought was innovative and spoke to their desire to help others is we had them participate in a peer volunteer activity. So we had community agencies in the area who were willing to have one of our participants go to their organization and be involved somehow with peers. They did a peer education. They would do a panel about living with HIV. They would help distribute condoms or discuss clean needles and why, or how to make sure, whatever role that the agency felt they would be willing to do. It took a lot to get these agencies to agree to bring active users into that role. But it was one of the most amazing parts of our study because people actually, a lot of them learned how to manage their drug use so that they could be attentive for a period of time while they were there, something that many of them hadn't done before. And it started to help them recognize they could actually be employed, and some of them ultimately got employed because of these experiences. And the agencies dropped some of their bias, where they're like, these folks are really smart and they really have a way to like tell their stories. And it's like, yeah, these are people with skills. So it was a really sort of uplifting study in that way. And the focus really, because that was the focus of our participants, was in the peer mentoring and of course the medication adherence and prevention. So in the equity lens, which we're talking about in terms of how to help you all make sure you're keeping your equity lens, is I'm talking about it in terms of avoiding the deficit model. We have this tendency to look at our things as a negative. What's lacking, what's defective, what's deficient, what's risky, what needs to be fixed, as opposed to what are the assets. So looking at both is important. I'm not saying that we don't want to look at some of the lacking, but we want to make sure that from an equity perspective, that we're also seeing the plus side, right? They're trying to find the other side of this. So, in an asset-based approach, we want to build on what's there in your local community. So depending on which populations you work on, and I have a list of what you're doing, so I'll get to those in a second. But it makes visible these skills and knowledge and connections in the community. So for us in Voice, it was recognizing that these individuals had really good skills to do this peer piece, and what was motivating them and what they got in some of the intervention sessions was how to have discussions with other users about getting tested, if they're positive, getting treatment. And we had role plays. I mean, there was all the skill building of our research. That was the intervention they wanted. The individual sessions often focused on their own risk behavior, but that was done individually. So we had sort of this combination. And so then I think about your populations and your MRPs and who are you working with? And how do we think about an equity lens, right? So I'm thinking, Pablo's group, right? I mean, so as you're thinking about your research project, I was wondering, so how are you, thinking about the different types of young gay and bisexual men? Is that, we want to think about our recruitment, and I'll go through the list of sort of areas where the equity lens might really impact, right? Where are we recruiting? Who are we recruiting? Are we paying attention to who is missing in our recruitment, right? The sort of equitable access. How are we doing this in our own processes? For me, a lot of the equity focus on projects is our research process. Is going to create more equity. Who do you hire? We were just talking about this. It's like we always hired from for several reasons. Not just because it might really make better science, but we are contributing to equity opportunity in these communities, at least temporarily. With all the caveats of going in and out, but temporarily people have jobs or projects. It's not an unimportant impact from an equitable standpoint. I think about college students, same question then, right? Like, who is actually in there? I mean, you and I had some discussions precisely because I'm like, wait a second, not just the ones who have substance use, because those are ones that got caught. So we want to make sure to not exclude others that might actually be more serious, but have learned how not to get caught earlier, right? So again, it's just thinking about what's the gap in your sample. If we think about the harm reduction workforce, who is that? Like, who who is represented in there. So just to be conscious at all times about, is it really bringing in different folks? In the CAP study, it's like, well, is this going to be, how are we going to create some diversity in your sample so that we hear voices that really are sort of, from different perspectives, possibly. How do we do that? And how do we make sure that people have equivalent access to participate, right? If you like, what barriers are coming in that might prohibit some people? So let's say you decide you can only interview at night. Well, you're going to impact a lot of people that way, or, so again, think about your own processes. Are you creating any of those barriers on that running track for others? And again, the same thing, in the international realm, there's more complication about what does this mean in these populations in terms of equitable access and who is being excluded and why. And again, our studies often require that. But if you're conscious of it, I think that it helps you think about, okay, who are we left out, and what is that okay? What do we need to know about those that we've left out? And again, with the clinicians, providers, same thing. It's like, make sure you're thinking about who do they represent? Because in your project, Sharon, you had staff and clinical providers. Those are very different, and I would want you to think about, the types, and maybe thinking about making some of that more consistent, so that you don't get what are very different life realities from folks, or at least address that very directly, those separately. So for me, the equity lens is often in our methodology. Obviously, how we analyze our data later, but I think how do we make sure that our researchers, as equitable as possible, is there equal access? Are you establishing trust? So the study staff, that's what we talked earlier about trust, and how do you build that trust with the folks that you're trying to work with? Can you make sure that you bring on staff that really are part of the community, have those skills, and that you're providing the training if they don't, right? I think one of the things that Kate has been really hearing from her study is how lacking of training for researchers and your research team. So be very mindful of how much you're training your team and what you're asking them to do, and recognizing what effect it has on them. One of the things I mentioned today was we actually had when we were in the middle of interviews or intervention protocols, we had a therapist who came once a week and met with our interventionists and our interviewers for a debrief, just a separate from the team. So the research team was not involved. I was not involved. It was this person that would come in and they would have a debrief of how they were doing, given everything that was being exposed to. And I think it really helped our team with their morale, and knowing every week, not the team review that we have in the first events, but where they could be with each other and really talk about the stress of doing these interviews or doing these interventions where they're managing active users in the room. I was looking over our protocol last night and remembering, we had a protocol. If violence happens during the group, what do you do? If somebody faints during the group, what do you do? If we have to call the police, what do we say and what do we do and how do we do it? Suicidality, which we had talked about, what do we do? Medical emergency, what do we do? So we had about 5-page protocol as we were doing this with a community partner. And so we made arrangements with them as well. Like, this is the protocol. Do you agree with this? They have a nurse on site. Could we ask her to come in under these circumstances? So these are all things, again, with making sure that you're taking good care of your participants in any way that you can. And then, of course, the other equity lens is, are you collecting relevant data that would be relevant to the people you're trying to help? I know that we talk a lot about putting other data that's interesting and that's good and things, but hopefully always the ultimate goal is how it's going to improve the health of the individuals that we're trying to reach. And so what can you do to advance? So these are just a couple of things to think about. Are you asking questions that highlight individual risk and can be experienced as blaming or shaming by your participants? Are there ways to avoid it sounding that way? Can you think of other ways, right? So, and some of it, is just in the wording, just thinking it through, just wanting to make sure that your awareness of how you're asking these questions. Again, are we going to go to the medical model that says, what did you do? You're a bad person because you did that, and that's why you're fat, and that's why you're have HIV. That's why, right? As opposed to maybe, broader questions that will help you understand the context of that risk. Are you framing your ethical issues or questions in a way that acknowledges the structural versus individual deficits? So again, considering the more upstream factors that might be contributing to the ethical questions at hand, does that lens change how you think about your ethical questions and dilemmas? Again, I was thinking as Natasha was talking about what was going on is she's looking at that individual thing, but all of our discussion went to the broader question, right? And that may ultimately be the bigger question for her, is how does this really impact not just that group at the harm reduction community center, but how does this, affect that whole community as they're trying to navigate services and stay out of the sort of sight of police and prisons. So, it's not a perfect thing, but this is really just ways to think about it. And there's a lot more that one can do, but just trying to keep that sort of equity lens as much as possible in your work.